Welcome to this short video in which I will introduce you to some concepts in patient safety. I'm Dr. Sheikh and I'm a pediatrician and professor at UC Davis Health. The objectives of this video are to define patient safety and describe the scope and systemic nature of preventable harm in healthcare. This includes recognizing that preventable harm is common in all sites of care, including outpatient, inpatient, long-term care settings, community care settings, and that improving safety requires acknowledging the scope of the problem. You will find out why a systems approach is used to recognize the causes of medical errors and safety failures. This includes understanding that most errors result from flawed processes or systems of care, reflecting predictable human failings in the context of poorly designed systems. And finally, we will look at some ways for frontline clinicians like us to improve patient safety. You will understand that promptly reporting patient safety concerns helps with health system-wide learning. Today, we are focusing on a critical topic in healthcare, patient safety. The concept that patients could be harmed while receiving medical care has been known for thousands of years, dating back to Hippocrates' phrase, "First do no harm." The World Health Organization defines patient safety as freedom from unnecessary harm or potential harm associated with healthcare. The first step in preventing harm is simply acknowledging that it occurs. The scope of this issue was highlighted in 1999 by the Institute of Medicine's report To Err is Human, which estimated that between 44,000 and 98,000 Americans die in health systems each year due to mistakes in their care. I was in the second year of my pediatric residency training in New York back then, and I remember clearly how this landmark publication marked the beginning of the modern patient safety movement. So why is healthcare so dangerous? The fundamental challenge is that diagnosing and treating patients is incredibly complex. Adverse events are defined as patient harm that arise from medical care rather than from the underlying disease. When looking at the causes of harm from healthcare, unsafe acts are generally categorized as errors or violations. Errors are typically slips or lapses. A slip is an observable action, like accidentally pushing the wrong button. A lapse is a failure of memory, such as failing to administer a required medication. A mistake is an action that goes as intended, but it turns out to be the wrong action. Finally, a violation is a deliberate deviation from a standard operating procedure. It's important that we also focus on the events where harm is averted, the near miss. This is an unsafe situation that is indistinguishable from a preventable adverse event, except that the patient avoids harm due to luck or early detection. Learning from near misses is part of continuous improvement in healthcare. Historically, healthcare treated errors as failings of individual clinicians. However, patient safety should take a systems approach. Safety failures are almost never caused by isolated errors committed by individuals. Instead, most errors reflect predictable human failings in the context of poorly designed systems. Therefore, we must recognize that most patient harm is caused by bad systems and not bad people. This perspective requires us to stop our historic response of finger-pointing, blame, and shame. Only about 5% of medical harm is caused by incompetent or poorly intended care. In contrast, 95% of harm involves conscientious, competent individuals involved in circumstances that led to a catastrophic result. Most serious medical errors are committed by caring, capable people doing what other caring, capable people would do. While we should not blame, individuals must still be accountable for their actions. The solution is to identify system flaws and change the underlying systems of care. We need to design processes that make it easy for people to do things right and hard to do things wrong. To understand how complex failures occur, you might hear about the Swiss cheese model, introduced by psychologist James Reason. The underlying cause of many safety incidents are latent errors. These are defects in the design and the organization of processes and systems. They're often unrecognized or just become accepted aspects of the work. Latent errors set the stage for active errors, which are the immediate actions of failures whose effects are felt right away. Imagine the layers of Swiss cheese as the barriers an organization has in place, like protocols or checks. Usually the holes, the system flaws, do not line up and the slices act as barriers. However, harm occurs because system breakdowns or these holes have aligned. Errors that lead to serious patient harm are rarely the result of just one error involving one person, but rather a series of errors or breakdowns in process. This model emphasizes that organizations must learn from all errors, even those that don't reach the patient. Significant improvements require commitment from individuals and organizations. Individuals alone cannot improve patient safety. It requires everyone on the care team to work in partnership with one another and with patients and families. As frontline clinicians, there are several things we can do to improve patient safety. First, following evidence-based safety protocols such as sanitizing and washing our hands to reduce infection. Second, communicating clearly, perhaps using tools like SBAR, situation, background, assessment, recommendation. Third, practicing situational awareness, which is the conscious knowledge of the elements of a clinical situation and the significance of how they relate to each other to cause harm. Fourth, taking care of ourselves. I've been there with you. Clinical environments are busy and stressful, but not paying attention to our rest, nutrition, hydration, stress level, and mental health can contribute to harming the very people we are committed to serving. And finally, emphasizing reporting of errors and near misses. Every error, even the ones that don't cause harm, represents an opportunity to improve our care. We know that voluntary reporting systems capture only 10 to 20% of actual errors, largely because the fear of a punitive reaction inhibits reporting. We are all part of fostering a culture where reported data is used for system-wide learning and improvement. The field of patient safety has matured since that time back in 1999 when I was a pediatric trainee. We have shifted from focusing on errors as individual failings to understanding them as flaws in complex systems. We've learned that patient safety improvements require a commitment to redesigning systems. The consensus is that we must shift from focusing on single types of adverse events to emphasizing the design of safer systems of care. This is because unsafe systems put patients at risk for many different types of errors simultaneously, requiring us to use insights from disciplines like patient safety science, quality improvement, and human factors to design safer systems rather than just implementing targeted programs to prevent individual harm. By acknowledging the complexity of healthcare, contributing to system-level changes, and doing our part as clinicians to follow safety protocols, communicate clearly, practice situational awareness, take care of ourselves, and speak up when we have concerns, we can do our part to keep our patients safe.